So good evening, everyone, and welcome. My name is Ida Fernandez. I'm the Vice President of Research and Patient Programs at Crohn's and Colitis Canada. On behalf of Crohn's and Colitis Canada and McMaster University, I would really like to thank everyone for joining us today in this patient education event. The Gutsy Learning Series is a novel education initiative spearheaded by McMaster University in collaboration with Crohn's and Colitis Canada. Now in its third year, this biannual series, made possible through generous funding support from Janssen Pharmaceuticals, aims to provide patients with the opportunity to learn more about the latest in Crohn's and colitis. Our event this evening is being broadcast live over the internet to enable participants across the country to join and learn alongside of you and participate in tonight's presentations. In fact, I understand that approximately 600 people have registered online, so it'll be important for us to keep on schedule. So just a few housekeeping items before we get started. For those of you here present, please note that the washrooms are located around the corner just outside rooms 3411 and 3412. For our online participants, should you wish to submit questions, you may do so by typing them directly into Ask a Question icon on the top left corner of the webcast link. Or you can email us your questions directly to learn@crohnsandcolitis.ca. Please enter your questions directly in the subject line, and we will try our best to raise them during the Q&A period at the end of our presentations tonight. Please note that we will take a short 10-minute break at 7:20, so please return promptly at 7:30 when our presentations will resume. Again, thank you all for attending, both face-to-face and online, and we hope that you will find tonight's presentations informative and that you leave with a broader understanding of some of the issues facing our individuals living with Crohn's and colitis. So for our first presentation, Dr. John Marshall will be talking to us about the new diagnostics in inflammatory bowel disease. What's up with testing? Dr. Marshall is a professor of medicine at McMaster University and the chief of service for gastroenterology at Hamilton Health Sciences. After completing his BA and MD at Queen's University, he undertook his residency training and Masters of Science in Clinical Epidemiology and Biostats at McMaster University. He's a full member of the Farncombe Family Digestive Health Research Institute, co-editor of the Canadian Journal of Gastroenterology and Hepatology, and he also serves on Crohn's and Colitis Canada's Scientific and Medical Advisory Council and our Grants Review Panel. Please join me in welcoming Dr. John Marshall.
Great. Well, thank you very much, Ida, for that kind introduction, and thank you also to Crohn's and Colitis Canada for supporting us, and also, of course, to Janssen for their support. Welcome to everybody in the room, and to all the people who are online. We're actually ahead of schedule. Hopefully that we stick to schedule as things go forward. So I was going to speak to you a little bit about something different today, which is talking about some diagnostic tests which have become available to us as gastroenterologists who look after people with inflammatory bowel disease, and of course thereby for all of our patients with IBD. And so this is entitled, What's Up with Testing? I thought I'd just remind you what we're dealing with. All of you, I think, are too familiar with what IBD is, and so just to show you some of our traditional endoscopic pictures of first what ulcerative colitis looks like. As you know, it's that inflammatory condition affecting the inner lining of the colon, always involving the rectum and extending proximally to a variable distance, and it differs among patients how far up through the colon it extends, but it really only affects the colon, and it has that sort of appearance when we do colonoscopy. Of course, Crohn's disease is the other condition that we are talking about tonight and managing in our clinics. And Crohn's disease often looks quite different at colonoscopy. This patient has some very deep sort of those white lines or ulcers affecting the colon, and Crohn's can have areas which are normal interspersed with areas which are affected. And of course, Crohn's disease doesn't just involve the colon. it affects potentially the entire digestive tract, as we like to say, from gum to bum. And so very similar conditions, but some differences as well. And what we're all trying to do is revert those conditions to what's at the bottom here, which is a nice, healthy, normal-looking colon, where you can see that nice, lacy blood vessel pattern. In the right light, it has a nice, shiny, smooth sort of look to it, and we are trying to, I think, achieve that in our patients with IBD. And that's where this idea of mucosal healing comes in. It's a buzzword that we like to use in gastroenterology. Mucosal healing really means making that lining of the bowel start to look normal again, and that really speaks to controlling the disease itself. And we hope that translates to people feeling better and having more normal quality and quantity of life. And that's really what we're striving to achieve. So as we manage our patients, a lot of challenges come up with how do we make the diagnosis in the first place? How do we determine whether Crohn's and colitis are active or whether they're in remission in people who have symptoms? And of course, how also do we use our treatments in the best way? Are there any ways we can optimize the therapies that we have to, make more of our patients go back to that sort of normal appearance and hence normal life? And I will say that in 2016, our goal of care is really that last statement, which is to give our patients with IBD a normal life experience. And we have far better tools than we did 10 or 20 years ago to do that. And part of those tools relate to testing. So I put this slide together because this is really what we're thinking of with when I term comprehensive IBD management. I think we like to focus a lot on our treatments, medications, surgeries, and that's one piece of the puzzle, but there are other things that come into play when we talk about managing patients with IBD. Certainly, Crohn's and Colitis Canada are here, a very important organization for advocacy for patients with IBD, and I think all of us in the room share that challenge to make sure that patients with IBD receive the care they need, they have access to the resources they need, and that the public understands the impact of IBD on all of you and all of our patients. So advocacy is an important part of this. Communication, and we've, I think, touched on this in some of our previous Gutsy Learning Series events, talking about how we can improve communication, for example, between patients and healthcare providers. And that's a two-way communication, of course. We need better tools to allow healthcare providers to understand the impact of disease on patients. And also, the healthcare providers, the research community need, I think, better tools in many ways to spread knowledge about what our understanding of IBD, both how it starts, how it behaves, and what can be done to help it. But a big part of this is how patients are evaluated. And so we haven't really touched on this in previous events in this series, and that's what I thought I would address today. And I'm going to focus really on three specific things that I think patients with IBD should be aware of. One is how we're looking at the small intestine these days, and we'll come back to that. But MR enterography is a form of MRI scanning that we'll talk about. Another sort of novel diagnostic test we have available in some centers in Canada is what we call fecal calprotectin testing. I'll talk to you about that as well. And something which is, I think, a lot of buzz in community of physicians looking after IBD, which is something called therapeutic drug monitoring. It's a little complicated, but I think you should have an idea of what that is, and so that you can ask the right questions when you or your family members are seeing gastroenterologists and surgeons looking after IBD. So we'll touch first on MRI scanning and MR enterography. Okay? So we'll come back to what that term means, but first talk about where IBD affects people. So we've already touched on this, but ulcerative colitis is a condition that affects the colon, and only the colon for all intents and purposes. Some patients just have very limited disease in the rectum. We call that proctitis. In other patients, the inflammation goes a little higher up that left side of the bowel, which is the right side of the picture, because that patient is facing you. We call that left-sided colitis. And when it extends all the way around the bowel, we call that pancolitis. And about 20% of patients will have pancolitis. Crohn's disease, of course, is a little more complicated. So there are some patients where Crohn's disease affects what we call the upper gut. So that's the beginning of the system, the food pipe, the esophagus, the stomach, and the early part of the small bowel. There's about a third of patients where the disease only affects the small bowel. It's not found elsewhere. About 45% of patients where both the small and large bowel are affected, and then about 20% of patients with Crohn's disease just have inflammation limited to the large bowel or the colon. So we actually often call that Crohn's colitis, and it gets very confusing because it sounds a lot like ulcerative colitis, but Crohn's disease in the colon is Crohn's colitis, whereas ulcerative colitis is UC, ulcerative colitis, but the terminology does get confusing. But Crohn's can be hard to evaluate and study because it can be so scattered in the places that it affects. So sometimes think of the small bowel as the final frontier in a way, because we have some traditional tests like endoscopy, the scopes. We can get through the mouth into the top of the gut. We can get through the other end through the colon and evaluate that fairly easily, although easy may not be the word that many of you apply to that test, but it's doable. But the small intestine is a challenge to really image accurately. And just some fun facts to remind you, there are 3 parts of the small intestine. So we call it the duodenum is the beginning part, the jejunum is most of it in the middle, and then the ileum is the bit at the end. And you'll often hear people talk about terminal ileum, or TI. It's a common sort of short form that we use in gastroenterology, and that just refers to the last few inches of the ileum, right, the last part of the small bowel before it joins the large bowel, which is statistically is the most common place affected by Crohn's disease. So duodenum, jejunum, ileum, and then lastly terminal ileum. You've got 22 feet of small intestine inside you. And if you were to flatten the small intestine out, remember the small intestine, its job is to absorb food. So it's got all these little structures, these little fingers, lots of folds, and even on the fingers of the villi that we see under the microscope, even the tips of the fingers have tinier fingers still that help to maximize the total surface area in the bowel. And if you're able to flatten all that out, it would be the size of a tennis court. So you've got a tennis court of surface inside which is absorbing food. And the small intestine sees about 6 to 12 liters of fluid per day, and its job is to extract food from that, absorb some of the fluid, and then deposit what's left into the colon. So it's a very important structure. And that's, in Crohn's disease, probably the biggest challenge is preserving small intestine function, because worst comes to worst, you can lose your colon, but you really cannot lose large segments of your small intestine. If you do so, your nutrition becomes severely compromised, and you might need other forms of nutritional support. So we're going to talk a little bit about diet. My colleague, the dietitian, will agree that the small intestine is an important part of the body. So we need to look at it well. So this is some examples of how we can look at the small intestine using our various diagnostic tests. So the top left is just a snapshot of a colon the small bowel seen through colonoscopy, because the colonoscope can go all the way up the large bowel, then push the tip into the end of the small bowel, and you can see that terminal ileum, the last part of the small bowel, and take pictures such as what you see there. So that's really our workhorse diagnostic tool. But of course, we can't reach through this entire small intestine with endoscopy, either from above or from below. 22 feet. You don't want us to try to do that. So it's very difficult to see. So we only see a small part of it. Traditionally, we have used barium X-rays, and many of you in the room may have experienced a barium study. Not done as much anymore. It's really, I think, retreating into the background for very special scenarios or circumstances. But the small bowel X-ray, also called small bowel follow-through, small bowel meal, you hear those terms. Those are all variations where the patient will drink the white chalky barium liquid, and it gets followed through the small intestine, often with the technician pushing and maneuvering and squishing things around to make sure that the barium gets all the way through. And a series of X-ray pictures are taken, and then the radiologist, the X-ray doctor, looks at all those pictures and issues a report. It's very labor intense, and also involves a fair amount of radiation exposure, because lots of pictures and even video get taken during the test. So we're not using that particular test so much anymore. For interest, I show you lower left, which is capsule endoscopy. Happy to talk about that in the question and answer. It's not used very much in Crohn's disease, but that's that pill camera that you can swallow, travels through you and takes pictures as it goes. So it sounds very futuristic and science fiction. We don't use it a lot in Crohn's disease because if Crohn's disease has any areas of narrowing, and we worry about something like that getting stuck. So not a very common test in Crohn's disease, but for some people it can be the right thing. A lot of interest in CT enterography. So enterography is just a fancy word for taking pictures of the small bowel, right? The entero is it works intestine and graphy is pictures, so taking pictures of the small bowel. So you can do that with CAT scanning. We do a lot of this still. It does involve radiation, right? So we don't want to overuse CAT scanning for this purpose. In fairness to our radiology colleagues, the new CAT scan techniques use a lot less radiation than the old ones, but still, we don't want people to have numerous CAT scans over the course of their career with Crohn's disease. Now, MRI I'll leave to the end, but another up-and-coming technology is ultrasound. Ultrasound is pretty common. It's pretty easy for patients to have done. But to take good quality ultrasound pictures of the intestine is a challenge, and it requires very specialized training. It requires not just the quick kind of ultrasound that you may have had in the past, but a lot of detailed study, and it just is not widely available in Canada, although some of our colleagues and colleagues at other centers in Canada are trying to, I think, create some interest in this and get some interest among our radiologists in doing these high-quality ultrasounds. But really a very promising and useful technique for looking at small bowel is with MRI. So that's MR enterography. So MR is magnetic resonance. So when we hear MRI, it's magnetic resonance imaging. So this is MR enterography, so using MRI to look at the small intestine. So the problem with all this is you've got to know what's available locally, and any or all of these tests could be appropriate for a patient with IBD, but it depends a bit on that patient's circumstance and the expertise of local providers and access to some of these resources as well. So even though I'll talk about MRI, you have to, I think, talk to your own physicians about what's appropriate for you and what's available given your circumstance. So MRI, so I think everyone may know a bit of what an MRI scan is. It's a technique that uses basically magnetic waves, to take images of your insides. And it involves a machine which is it's a ring with a tunnel inside. The patient lies on their back and slides through the tunnel as the images are taken. Lots of variations in how it's done from center to center, but in some cases it involves a clean-out similar to what's done with colonoscopy, but often not. In fact, patients usually just have to fast before they come to the hospital. It is a magnet, so a key part of MRI is being able to remove all metal before you have the scan, and particularly metal which can be magnetized, so that we call it ferromagnetic metal. So not every kind of metal will actually pull towards a magnet. And thankfully, a lot of the metal used for surgical things like hip replacements and clips from surgery are not magnetic, so you don't need to worry about that. But anything that's potentially magnetizable has to be removed. So that includes jewelry. And if patients have worked as a metal grinder years ago and they think they might have gotten a metal fragment in their eye, we have to do x-rays to make sure that's not there. Because if you have metal inside you and you stand next to a magnet, the metal will find its way out, and that can be an unpleasant experience depending on where the metal is. So very carefully removing all metal. Typically, when you come for an MR enterography, you have to drink some fluid at the time you arrive, usually about an hour before the test. And that's specifically so that the intestine is full of fluid, and you can highlight it. It makes it easier to see the wall of the intestine on the test. So you're asked to drink some fluid, and different centers use different things. A very dilute version of the barium we talked about before. Sometimes it's something called sorbitol. But you are asked to drink some fluid, and typically you're also given an intravenous contrast as well, something called gadolinium. Not the same as what you're given when you have a CT scan. So a common question is that people have an allergy to the X-ray dye used in CT scans. It's a different dye that's used for MRI scans. Sometimes they give you another medication called glucagon that relaxes the bowel so it stays still for the MRI scan. And then you, as the patient, would be lying on the table, sliding into the machine, and asked every now and then to hold your breath, keep things still, so they take a series of pictures. It can be a little claustrophobic. It's a small tunnel, so some people have difficulty with that. That's one challenge with MRI. Usually you're given some headphones and some music to keep you distracted during the test. And it typically takes 30 to 45 minutes to get that done. The result of MRI enterography is some really beautiful pictures, actually, if you detach yourself from what they're actually taking pictures of. But the images are fairly good, high resolution, and you can see a lot of detail. This is just a couple of examples. So this is in someone's inside cut vertically, top to bottom. And so you can see that person's liver in the top left of the screen. And all these tubes that you can see are the small intestines. And you can see a lot of detail in these small intestines. You can see all the little folds and divots in the wall. And so you can really get a lot of information from an MRI scan. And unlike barium, which just basically looks at the X-ray dye as it goes through the tube, where you really see the contour of the inner lining of the tube, one advantage of MRI and also of CT is that you see everything. So you see the full thickness of all the wall of all the intestine. You don't just see the innermost surface, you can actually see the full thickness. And that can be very useful information. So just an example of someone with Crohn's disease having an MRI scan. You can see that this part of bowel looks a little different with all the arrows. Arrows always, in the X-ray pictures, always point to the problem. And the arrows here are showing a section of bowel which is the wall is more thick than normal, and it has that sort of white lighting along the wall. It looks all lit up. And in some forms of MRI scan, something we call T2 weighting, it lights up areas which are inflamed with a white color. So it can be very useful in seeing whether a part of the intestine is actually inflamed and swollen. Okay? Because water in the wall of the bowel turns a bit white under this technique. And another example on the right side of the screen of a section of bowel which is inflamed. So that is a very useful thing. We often get people with Crohn's disease who have areas that are narrow in the bowel, and we're trying to figure out, is that just scar tissue from old disease, or is it actually inflamed and might benefit from new medications to try to settle that inflammation. An MRI scan often can help to adjudicate that and see whether it's scar tissue or something active. And this is an example of a patient who got treated for their Crohn's disease, and the MRI changed a little bit. If you can make this out on the screen, and the top is before treatment. You can see the wall of this part of the bowel looks very white, and at the bottom the wall looks a lot thinner, and you've kind of lost that white color, and that's inflammation settling down with medical treatment. And this patient actually had a colonoscopy done as well, so the scope also showed the same thing. So the MRI scan, the scope showed the same thing. So it can be useful for tracking disease over time, seeing if it gets better. And this is a study which was done showing that the dots kind of go along a line, which means that the score that they get from endoscopy kind of correlates pretty well with the score that was given from an MRI scan. So it's in some circumstances can be a good substitute for endoscopy. There's generally good agreement. So I think the pros and cons of MRI, we certainly have welcomed access to MRI scanning. And in Hamilton, we have pretty good access. And now in most places across Canada, there's decent access to MRI scanning. And I would emphasize it's not just the MRI scanner, it's the radiologist, the X-ray doctor who's got the expertise in looking at the pictures. So just because your town has an MRI scanner doesn't mean they can do MR enterography. You have to have the X-ray doctor, the radiologist who's trained in reading the pictures. Lots of advantages. No radiation. That's probably the most important thing. We've become very worried over time that our patients with Crohn's disease get too many X-rays, too many CT scans, too many barium studies. And sometimes there's no choice. You've got to do that depending on the circumstance. But we are really welcoming ways to look at the disease without involving radiation. Another example, another advantage, of course, is not just looking at the innermost lining, as I mentioned. You actually see everything in the abdomen, including the whole thickness of the bowel. So you can see, get a lot more information. And this is what I talked about, trying to look at the difference between scarring and active disease. There are some challenges. It is a small tunnel in most MRI scanners, so if you're claustrophobic, it can be a bit of a challenge. Some centers do have special MRI scans that are a bit more open, but they're very rare. That fluid that you have to drink can upset some people's stomach and even give diarrhea, so for patients with Crohn's and colitis, that can produce a challenge. Access is still a bit of an issue, and the wait time for MRI scan in most places is longer than some of the other tests I mentioned. So you have to know, again, what's available, and sometimes we just can't wait, or sometimes we have to pick up the phone and beg and plead with our radiologist to get a patient in sooner if they need it. It does have a cost associated with it. I would argue that that cost is a good investment given the concerns about other tests, including radiation exposure. And I just introduced this idea of the incidentaloma, too. That's the medical word we use. When you take x-ray pictures of people, we're looking at the small intestine, but you can't help looking at everything else. And sometimes you see a little bump or a little something looking a little funny somewhere else, and then we end up doing other tests to try to figure out whether that's something to worry about or not. So there's a big debate in medicine about what to do with these little lumps and bumps that you find elsewhere in the body when you put someone through an MRI scan. And probably most of us in the room, if we got put through an MRI scan, we'd find something that looked a little funny. And so sometimes you lead to other tests, and that's a consequence of doing these things. Anyway, I thought you should be aware that this is really becoming the standard for looking at the small intestine. And because time is limited, I'll move on to a couple of other things and talk to you a little bit about fecal calprotectin. So fecal calprotectin is something we can measure, okay? It's a long word, but calprotectin is a specific chemical, it's a protein that we can find in the stools, hence fecal calprotectin. It's something that's in the white blood cells, a particular kind of white blood cell called neutrophil. And when something's inflamed, you get a lot of neutrophils in that area, a lot of those white blood cells. And when they release their contents, when they break down and when they do their job, they release their contents and they release this chemical called calprotectin, right? So when something's inflamed, all those white blood cells are there and they're releasing this thing called calprotectin. So it makes sense that if the bowel is inflamed, white blood cells are lining the gut because they're fighting that battle, all that inflammation is going on, and if you look at the stool of patients with inflammation, you'll find higher levels of calprotectin, right? So when the GI tract is inflamed, the level of calprotectin in the stool goes up. And we think about inflammatory bowel disease, Crohn's and colitis as a cause, but in fairness, it can happen in infection. And if you take a medication that causes some bowel damage, and the classic thing would be like aspirin, Motrin, Advil can irritate the gut, they can put it up as well. But it's a way potentially of measuring how inflamed the bowel is by analyzing the stool. And the key thing in terms of practical is that if you take a stool sample from someone and you're deciding you want to measure calprotectin, that stool sample is stable for up to a week, so you don't have to rush down to the lab. You don't have to put it in your fridge. It can sit on the kitchen counter for up to a week before it gets processed, and it's still valid. And that's very useful for practical reasons, because if you take a stool sample from someone, it can be sent through Canada Post quite easily. And so a lot of programs will have kits mailed to patients and have the sample mailed to a lab, because we don't have to worry about refrigeration. A lot of things we do have to be refrigerated, right? Blood tests, for example, have to be stored very carefully. But this has a very practical advantage. And this is a sampling kit called the Easy Sampler. And I don't know why the husband and wife are happily arm in arm discussing their stool sample, but that's what it is. So easy technique. And I won't go through too much in terms of numbers, but there are lots of studies done that showing that the worse the inflammation in the bowel, the higher that level in the stool, the higher the calprotectin level. And this is example from ulcerative colitis. You've got people whose disease is mild, moderate, severe. The higher the activity in the bowel, the higher the level of calprotectin, right? So it's not just yes or no, is it inflamed, but it tells us a bit about how inflamed it is, how bad it is. And the same thing in Crohn's disease. The worse the disease, the higher the level of this calprotectin in the stool. There's some debates here and there, but in general that holds true. So how might we use it? Well, this is an interesting study I thought I'd show you from a couple of years ago, where they had patients send in stool samples every couple of months. And so you get sample, sample, sample. And what they noticed in this study was that they could see that level of calprotectin go up even before people started to feel symptoms. So maybe you can detect something brewing before it actually causes trouble, and maybe you can act on it. So that's one example. And we've got numbers here. I don't want to get too hung up on the numbers, but if it's low, then probably good news. The disease is under good control. We can continue on treatment. If it's high, then maybe the disease is active. Maybe we need to do some more tests, and maybe we need to change the treatment, right? So you can kind of use these tests in that way. And there are a bunch of scenarios where we've been using this in practice. In Hamilton, I'll come back to how you access it because it's not available everywhere, and I think it would be important for all of us to advocate for better access to these kinds of tests. But for a family doctor, if some people come with diarrhea to a family doctor, it can be useful to figure out, well, who needs to have more testing done and who doesn't. So family doctors can potentially use this test to figure out whether there's something going on like Crohn's or colitis. And a lot of frustration from patients is how long it takes to get diagnosed with Crohn's and colitis. And if we had better tools that family doctors could use, maybe we could shorten that delay from symptoms to diagnosis. So this kind of tool could be very useful in primary care. When people we know they have Crohn's and colitis, we can use this as a screening test to figure out whether it's active or under control. We kind of use it. We don't like to overuse colonoscopy. I don't think any of you want us overusing colonoscopy, but can help us try to decide who needs to undergo colonoscopy, right? So if you have just some minor symptoms and the calprotectin is very normal, maybe we can avoid putting you through tests. Whereas if you have some symptoms and it's high, maybe we need to do more and do the colonoscopy. So maybe we can save some people colonoscopy. Maybe we can use it to predict who's going to get sick. From the study I showed you before, we often use it when we start new treatment to see whether it's working. You want to see that calprotectin level coming down, so it can be an early sign as opposed to doing colonoscopy. And when people feel fine, we might still measure a calprotectin because we're always worried about kind of grumbling disease that's not causing symptoms but may cause challenges in the future. So a lot of scenarios that we can use this sort of test in practice. It's not perfect. Sometimes you get values that just don't make sense. So I think ideally we'd like to use this repeatedly, not just one time, but follow people over time. Access is a problem. We're very lucky in Hamilton because our hospital provides that test for free for patients who are followed in our clinic. They've agreed to do this, but it's not something which is on the list of tests that the government pays for. There are some other ways to access it through some of the support programs for some of the medications we use and also through some of the special pharmacies, but in general it can be hard to access. It is available for cost from Life Labs and other private labs, but it's over $100 to get the test done. So I think we're lucky to have it in Hamilton. We're very hopeful that this will become more available across the country, and I hope all of you can help advocate for access to this kind of test within the public health care system. And of course, there is a bit of an issue with patient acceptance. No one really likes to collect stool samples. But if, I've been surprised how accepting our patients have been, particularly when we can potentially avoid a colonoscopy with the right results. So that's encouraging. So just in the last few minutes, I'll move on to the other area I was going to cover, which is something called Therapeutic Drug Monitoring, or TDM. And that's really specifically related to what we call our biologic drugs. So most so with Infliximab, also called Remicade, but also with the other biologic drugs like adalimumab, golimumab, and vedolizumab that some of you may know. But we know most about this in relation to Infliximab. And probably the challenge with these new medications, which are very effective in many people, and I think they've really changed the face of Crohn's disease and ulcerative colitis, is that some people have a great response up front, but over time they kind of lose that response a little bit and find it's not working quite as well as it used to. So some people over time lose their response. We call that loss of response. So we need to understand why that happens to some people. And well, without getting too scientific with you, when you give a drug to you, the level goes up, and then over time that level drifts back down as you get rid of the medication, and then you get another dose, the level goes back up, okay? So you get a peak level when it goes high, but as the level of the drug drifts down, you get a low level, and because it's the bottom, called a trough, right? Sounds like it's a good word for that. So we talk about peak levels and trough levels. And it turns out that the trough level of drug can be very important. And so the level of biologic drug in your system just before you get the next dose, that's its low point, can be a predictor of how well your disease is controlled. So again, this is a study actually done in Toronto. It was a very influential study around the world. It was one of the first that showed that patients who had good levels of drug just before they got the next dose, so they didn't dip too low, tended to do better. So that means that levels stay pretty well all through time. It never dips too low. Those people tended to do much better than the patients where the drug was all gone from their system before they received the next infusion. And so this idea of measuring that drug level before you get a dose is a big topic of discussion in my world when we discuss how to manage patients with Crohn's and colitis. And I think you should be aware of this if you're on these kinds of medications. So, and we know that these levels vary among patients. People get rid of these drugs at different speeds. Some people clear them very quickly, some people very slowly. And if you clear them too quickly, the drug's out of your system, and it makes sense that it's not doing its job so well. And that can relate to lots of things, including the fact that some people make antibodies against these drugs. These are what we call biologic drugs. They're proteins, and your body can figure out it's not supposed to be there, make an antibody against it, and that antibody helps to clear it from your system faster because your body's trying to get rid of it. But lots of other reasons can make the drug disappear quickly from someone. So then we get to these, then we can do these tests, right? So what we tend to measure is both the level of drug in the body before you get the next infusion, see how low it goes, as well as whether or not your body's made those antibodies to kind of get rid of the drug, okay? So if you've got a low level of drug, and your body's not making any antibodies, so it's just disappearing for other reasons, well, we can probably help you by giving you more medication, right? Just boost the dose up, give you more, so we keep the level higher, that should work. And, you know, but if you've got a low level and your body's getting rid of it, as fast as we put it in, the body's getting rid of it with antibodies, there's probably no point in giving you more of that medication. You might change to a different medication. Whereas if we measure the level of drug, and it's good, got lots of drug on board, but your disease isn't well controlled, well, we just need to switch to a different kind of medication, right? So it can help us try and decide what to do when you're losing response to these medications. So we typically do this kind of test when a patient did well on a drug like Infliximab or adalimumab and then seems to be losing response to try to answer some of these questions. But there are other scenarios where we might consider doing it in the future. But most of our knowledge is around using it in patients who initially did well on a biologic drug, and then that effect seems to be waning a little bit, because trying to decide whether to give more drug or change to a different medication. It can be very helpful that way. So again, we come back to this idea of comprehensive IBD management, so focus a little bit on valuation, because I think that's an important piece of this puzzle. And it's very easy to talk about drugs, treatments, and surgeries and things like that, what we can do, but really trying to decide when to do it and trying to decide what to do when those things don't work is a very important part of management, and we're getting much better diagnostics. I will say that, again, we talk about advocacy as well on the bottom right here, that advocating for better access to diagnostic testing is such a crucial thing. In Ontario and in many other provinces, there's really not a lot of enthusiasm among public health plans about adopting new diagnostic tests, even when you can show that they save money in the long run. Governments really don't like listing new tests. So I think hearing voices from the public about the value of these things is important, and I'm sure Crohn's and Colitis Canada will be helpful with that. So last slide, just to think about where diagnostics might go in the future. I've shown you some very specific diagnostic tests, but there are other things that we'd like to have better tests for. You know, we talked about that fecal calprotectin level and for family doctors helping them figure out who might have Crohn's and colitis at an earlier stage. We really like to have tests that we can do before people have any symptoms and figure out whether they're at higher risk of Crohn's or colitis, and maybe do some preventive care if we can identify those people. And a lot of work around the world trying to find those kinds of things. Looking at better ways to measure disease activity so we don't have to do MRI scans and colonoscopies as much. We really want to have tests that tell us, you know, if we have two patients with Crohn's disease, who's going to have an easy ride and who's going to have a really challenging disease course, because we can put more resources and more treatments into the patient who's going to have a worse course, and we don't really have those markers yet. And also trying to figure out which drug matches which patient. IBD care is full of a lot of trial and error, but if we could figure out that this drug is the one for you based on a test, that would be very useful, get you better faster, and avoid unnecessary kind of trial and error with medications. Now, emphasize that the GEM project, which is something supported by Crohn's and Colitis Canada that I hope most of you, if not all of you in the room, are aware of, is going to make some contributions to this, particularly around some of the biomarkers, because this is a study looking at relatives of patients with Crohn's disease, trying to figure out who develops the disease and why, and hopefully this study will lead to some new markers that we can use to figure out who's at risk of Crohn's disease. And I'll stop there, and I think we'll have time at the end for some questions, so thank you.
Thank you so much, Dr. Marshall, for a very informative biology lesson and also demystifying really all the different diagnostics that are used in inflammatory bowel disease. So that was very, very informative and interesting. So just to remind the participants online